So, wonderful day, everyone. Today, we are about to report a case study named Black Death. The case is about fatal laboratory acquired infection with attenuated Yersinia pestis strain at Chicago, Illinois in 2009. The first topic will be the background, which will be reported by Lykha DUMAGO.
This case study revolved around a 60-year-old man who was a researcher from a university laboratory. Unfortunately, the patient died of cardiac arrest after he was rushed to the hospital on September 13, 2009. But upon further investigation, it was identified that he had contracted Yersinia pestis. Now, a little bit background about Yersinia pestis. So this pathogen was responsible for the Black Death or the bubonic plague that had occurred in the mid 1300s. But the mystery behind this case was that the strain of Yersinia pestis that the patient had acquired or had contracted was the pigmentation negative KIMD27 strain. Now, this strain was known to be attenuated, meaning it's less virulent and is less infectious. Now, the question is, what was the real cause of death of the patient? Now, moving on with the symptoms. On September 10, 2009, the patient was evaluated in an outpatient department for fever, body aches, and cough of approximately 3 days in duration. Now, the attending physician suspected that it was influenza or an acute respiratory illness, so he was referred to an emergency department. But the patient refused to seek further medical attention, or he didn't seek further medical attention. Now, 3 days later, on September 13, 2009, the patient was rushed to the emergency department with the following symptoms: a fever of 38.3 degrees Celsius, distant breath sounds, abdominal distension, peripheral cyanosis, and trace pedal edema. Now, it was suspected to be congestive heart failure, so he was treated with diuretics and antibiotics. So approximately 12 hours after he was rushed to the hospital, the patient got worse and he was intubated. So an hour later, the patient died due to cardiac arrest.
So the next will be laboratory findings. On September 13, 2009, the patient was scheduled for test on blood chemistry and it showed renal failure, which means his kidney were not functioning well. And the creatinine result were 6.5 mg per dl, which is very alarming since the normal range or the normal value is supposed to be 0.6 to 1.2 mg per dl for males. His blood urea nitrogen also was very alarming since the result is 73 mg per dl and the normal value is supposed to be 7 to 30 mg per dl. The patient is also diagnosed with incipient acidosis. Incipient means developing, and acidosis means increased acidity in blood or other body fluids. The bicarbonate of the patient is 17 MEq per liter and below normal range of 23 to 30 MEq per liter. His partial pressure of carbon dioxide is 31 mm of mercury, which is also below normal range of 35 to 45 mm of mercury. The patient's blood pH is within normal values, but overall value signifies an acidosis. The patients also have elevated function enzyme, which means the patient is also suffering from inflammation or damage to cells in the liver. The patients are aspartate aminotransferase or AST and alanine transaminase or ALT is very high and very alarming, and it is a common sign for a liver failure. His AST were 794 unit per liter and the normal value range is supposed to be only at 5 to 40 units per liter of sebum, while his ALT were 160 units per liter, and the normal value range supposed to be only at 7 to 56 units per liter of serum. And by September 13, 2009, blood cultures also drawn on the previous day yielded gram-negative bacilli 4 of 4 bottles and also gram-positive cocci 3 of 4 bottles, and yeast is 1 of 4 bottles and presumed to be contaminant.
Continuing our discussion on laboratory findings, we now go to September 15, 2009. Now, the clinicians identified the organism to be a gram-positive cocci. Specifically, it is fastidious or nutritionally variant streptococci, or we might call as NVS. But when the autopsy came, the symptoms were not the same with those associated with NVS infection. Now, that's a question right there. We now go to the next day, September 16, 2009. They were trying to culture the gram-negative organism, but of course, it was growing slow. But then the emergency department physician found out that the patient was actually a researcher that is involved with biologic agents. So the physician immediately notified the hospital staff. Then come September 18, 2009, remember our introduction? At that day, the hospital did the 16S ribosomal DNA sequencing. In this process, they took the DNA that was extracted from the sample, and then the 16S portion of the ribosomal DNA was amplified. Now, sequences with identity scores to well-characterized 16S sequences greater than 97 identity were resolved at the species level. But between 95 and 97, they were resolved at the genus level. So now they narrowed down the organism to be the gram-negative bacilli, Yersinia pestis, or Yersinia pseudotuberculosis. And on that the same day, they also notified the CDPH of the suspected Yersinia pestis case.
The next topic after the laboratory findings is laboratory and pathologic testing. So the University Research Laboratory conducted a preliminary PCR or polymerase chain reaction and microbiologic analysis in which they identify an organism which is PGM negative or pigmentation negative attenuated strain of Yersinia pestis. So attenuated means a strain of certain organism which is less virulent or less harmful or unlikely to cause disease. So those characteristics, the PGM negative or pigmentation negative attenuated strain of Yersinia pestis is consistent with the KIM D27 which the patient worked, and not the virulent strain of Yersinia pestis which is the CO92, which is being experimented and worked at separate lab facility on another floor. So the two strain of Yersinia pestis are being studied at the same time but at the different lab facility. To further confirm and determine which of the two is the real pathogen, the CDC compared the virulent level of the two strains in which they have injected the Webster mice. So the Webster mice were inoculated subcutaneously with varying doses. So for KIMD27 strain, they infected the mice with 1,000 to 100 million colony-forming units, while for CO92 strain, they infected the mice only 100 to 1,000 colony-forming units. And the results with CO92 is median lethal dose or LD50, which means 50% or more mice died. So the result shows that after injecting the mice with KIM 27 D27 strain and with very high doses ranging from 1,000 to 100 million, only 3% of the mice died. While on the CO92 strain, 50% or more died. But the doses is low, ranging from 100 to 1,000. So the result shows that only CO92 strain is the virulent and not the KIMD27 strain. So that's all for laboratory and pathologic testing.
As we were discussing the laboratory findings and the pathologic testing that was done on the patient, now we move on to the lung pathology images. Because the epidemiologists were trying to find out what type of plague caused the death of the patient. Now this might be interesting. If you turn to your screen, you can see there photos of the biopsies from the lungs, or alveolar biopsies that were procured post-mortem. On the top left, you can see a patient with primary pneumonic plague. Okay? Now, when you go to the top right, you will see the biopsy of the deceased researcher. Notice any difference? On the left side, we can see that the lung tissue of the patient with primary pneumonic plague shows extensive inflammation and no open air spaces. But when we go to the researcher's biopsy, the post-mortem lung tissue from the deceased researcher shows open air spaces and preserved alveolar structure, indicating that the deceased did not have pneumonic processes consistent with plague. Now, when we magnify the post-mortem lung tissue in the bottom, the one with color, it revealed that gram-negative bacteria were in the lumen of the pulmonary blood vessel. Now, what does that mean? It has confirmed the suspicions of the epidemiologists that the researcher or our patient died from septicemic plague and not pneumonic plague, even though the symptoms were coughing, were having fever, but in the end, they have concluded that it was septicemic plague that took the life of our patient.
So next is conclusion. Findings suggest that the strain with which the patient was infected was attenuated, and there is no new virulence mechanisms were acquired by or engineered into the infecting strain. Genetic tests found that the patient was homozygous for the HFE gene C282Y mutation, and they confirmed that it is a post-mortem inherited hemochromatosis diagnosis. So, hereditary hemochromatosis is a genetic disorder that can cause severe liver disease and other health problems. Early diagnosis and treatment is critical to prevent complications from the disorder. So, in histologic staining of the patient, there is an abnormal iron deposit in the liver. Since sinabi ko kanina during lab findings that his ALT and AST were elevated, meaning his liver do not functionally well, or probably it is a liver failure. So, hemochromatosis is an iron overload disease characterized by increased iron absorption and progressive iron storage in multiple organs, and the person with hemochromatosis are especially susceptible to infection with Vibrio vulnificus, Listeria monocytogenes, Yersinia enterocolitica, and Yersinia pseudotuberculosis. So, anti-Y pestis mouse monoclonal antibody revealed abundant staining of Y pestis in blood vessels of multiple organs consistent with septicemic plague. So, septicemic plague is characterized by the sudden onset of high fever without associated bubo or other obvious localizing signs. Illness is rapidly progressive, leading to the overwhelming sepsis and organ failure within a few days. So, there is a recent study demonstrated that intranasal infection of mice with KIM-D27 can result in persistent colonization of the lung vasculature, subsequent dissemination of infection, and eventually death without classic pathologic signs of pneumonic plague. So, CDC was also revealed preserved alveolar structure without inflammatory infiltrates that would have indicated pneumonic processes consistent with plague.
This was Dr. Malcolm Casadaban, the researcher who got septicemic plague from his attenuated Yersinia pestis strain. His death was a very unfortunate one because due to his hereditary hemochromatocytosis, his supposed to be attenuated KIM-D27 strain began feeding on this excessive amount of iron in his body resulting from his genetic disease. That caused it to become more infectious. That would be all. We hope you learned something. Thanks for watching.